Thank you so much. It's such a pleasure to be here, and thank you for organizing everything. I'm quite happy to be here and hope this will be found useful by all of the Photonics Society here. So I will see if I can advance my slides appropriately. There we go. All right, let's get going. So the title of the talk today, I was asked to talk about mental health for scientists, as well as specifically addressing the challenges that happen in isolation that have occurred due to the worldwide pandemic that has swept the globe in the last year. So I want to start off first with, I know that this is a potentially global organization and audience. So if you are in crisis or need emergency help, if anything during this talk, we are going to be talking about mental health, mental illness, suicide, and various things that might bring something up for someone. So that's totally fine. But please, if you do feel like you might need some help, find your local 24/7 hotline or local emergency services. If you don't know what those are, there is a website that has www.iasp info/resources/crises_centers. And that's the British spelling of centers. And this has every country listed. So please go ahead and go there if you need it. And I will start with a disclosure not a disclosure. I will start with the fact that Dragonfly Mental Health is not a mental health care provider. I am a mental health researcher, not a provider, not a clinician in any way, shape, or form. And so the information we're going to be providing today does not qualify as medical advice and does not substitute for speaking to medical professionals. So I'll be speaking from the literature, from the information we have, and then a little bit from personal experience. But this is not medical advice for you. Seeing a doctor, seeing a clinician is the right thing to do if you want specific advice about your own case or people you know about and care about. So the outline for today's talk is I'll do a brief personal introduction, a little bit more about my research and background and how I came to be involved in Dragonfly, and then tell you just a smidgen about Dragonfly Mental Health, the nonprofit itself and what we do. I'll touch on what this talk is meant to be and what it's not, just to make that abundantly clear. And we'll introduce the concept of mental health being on a spectrum. We'll focus in on, this is a bit of a hybrid talk between two things that we at Dragonfly have developed, between a mental health awareness talk and a mental health during isolation talk. And so I'll briefly go over a few of the top issues that people in academia, scientists, researchers tend to face. Mood disorders and anxiety. I'll touch on burnout and substance abuse. We'll talk a little bit about treatment and prevention throughout that segment, and then I'll spend the rest of the time talking about isolation during the pandemic, some of the impacts and some of the things you can do. So at the end, we're hoping to have about 15, 20 minutes maybe to speak as a group. So I will bring your attention to, at the top or the bottom of your Zoom screen, you should have a Q&A section. So you can type questions at any point into that box, and then we'll try to get through as many of them as we possibly can at the end together. So a little bit about me. I have been involved in research for 16 years now. I started as an undergraduate studying protein evolution and got my PhD in molecular and cell biology from University of California, Berkeley, and then studied psychiatric epidemiology at Johns Hopkins as a postdoctoral fellow. So I have studied mental illness and brain and behavior all the way from molecules to populations. And it's been amazing. I love it. As Akil mentioned, I'm still actively involved in the American Medical Informatics Association, still conduct research in collaboration with a hospital system called Geisinger. But in the majority of my time is now being spent leading Dragonfly Mental Health, a nonprofit organization focused on cultivating excellent mental health among academics worldwide. And this is because starting in grad school, I ended up getting involved in peer-led organizations focused on my colleagues, researchers, scientists like myself. These were by students for student organizations focused on mental health. And that was because we very tragically lost a classmate during my graduate years to suicide and depression. And that really woke us up, and that got me started on this path towards advocacy. So both at UC Berkeley and at Johns Hopkins, I've been involved in starting these peer-led organizations. And ultimately, it wasn't enough to have these grassroots efforts only. And so in 2019, I was presented with an opportunity to partner with a lot of people around the world, and we founded Dragonfly. So Dragonfly Mental Health is a global consortium focused on academic mental health. And we have a large group of volunteers from all over, all disciplines, that are interested in conducting research and addressing the big systemic issues that are facing our communities, research scientists, people in academia predominantly, but also folks who have gone through academic postgraduate education and are now in the workforce as well. We are working hard to build community around the world as well. So we have something that we conduct every week. We have 3 sessions, Dragonfly Cafe. And so this is a free, open place for any academic to come and speak about mental health, their own, or if they're concerned about things, or it's a peer support network. So Dragonfly Cafe is a wonderful way to build community, reduce stigma, and find other people who are interested in solving the problems that we have in academia and as scientists around the world. And then this is one of the pieces of our on-campus program, or I guess it's getting, this is an association program, but it was built off of the concept that in order to create culture and climate changes, we have to go directly to the academic communities themselves. Every culture, every country, every university, every department, every association has its own climate and culture, and that's built by the people. So we have to bring it specifically to the people, get people engaged. So we've designed a theory of change for how do we accomplish this and create systemic change. And we've identified 5 domains of excellence. You can read more about this on our website, but we work with every single community to customize each talk, each anti-stigma campaign, and we recognize that everybody's needs are different. So I just want to highlight, this is not, I'm speaking today, but we have an incredible amount of wonderful volunteers, all academics themselves, from all over the world, all walks of life. And, this work wouldn't have been possible without it, including Akil here, who has joined our team and has just been an incredible boon to the work that we're doing. So now let's get to the talk itself. This talk is meant to be a brief mental health introduction, and then discussion about the isolation and loneliness people can be experiencing during the pandemic. It's meant to be the beginning of an ongoing conversation about mental health literacy, about culture change, and about response preparedness. It is not meant to be comprehensive. It's not a response training, and it's certainly not everything you need to know in a nutshell. I've been studying mental health, mental illness for 16 years, and I even know just a sliver of information. So can't cover everything in an hour. So I'm going to introduce the idea of a mental health spectrum. It's a very brief overview, but like any form of health, mental health is something that can be optimized, good. So you can say mentally healthy individuals are folks that, or is a state that people can experience where they're generally resilient, generally in a good place, can deal with the normal minor things that come up day to day. It's very normal for every single person to experience stress, normal stress, either expected or unexpected, can come up. And when somebody becomes stressed, they might be, experience some symptoms of panic or a little bit of agitation or a little bit of sadness, depending on what's going on for them. But a state of stress is pretty easy to go back into a mentally healthy state once either the stressor has been relieved or ended, or employing a couple of simple things that doesn't take a lot of effort. There's another point beyond stress that we call distress, which is something it's lasting a little bit longer. It can be from chronic stress potentially, and it's impacting your life a little bit more, to the point where it is harder to get back to that mentally healthy state. It takes longer, or it takes more effort, or maybe even takes some intervention, like seeing a counselor or speaking to friends, or really taking time off. The next state in the mental health spectrum is what we're going to call disease or illness. And this is where you're actually diagnosable. So if you go see a clinician, you meet this criteria, and we'll discuss what exactly that means a little bit later in this talk. But it's diagnosable, it's impacting your life, your work, your relationships, and is often a state that does not allow you to get back to a mentally healthy state without some kind of psychological or pharmacological intervention. And then the final point of the spectrum, which really unfortunately in academia and in research science, we tend to let everybody get to a crisis state and let ourselves get to a crisis state before we even are willing to seek help, when we have lost the capacity to, on our own, get back to a mentally healthy state. And so crisis can look like, wanting to hurt yourself or others, being at risk of that, potentially being so incapacitated that you really require immediate care, immediate help and intervention, and often cannot do it on your own. So that's crisis, and that's what we really ought to try to avoid at all costs. Sometimes it's unavoidable, things come up very quickly, but it's something that happens far too often. So prevention is really focusing on all the states before you get to disease and crisis. But right now I'm going to focus in a little bit on the disease state and talk about a few of these. We don't have time to go through all of it. So there's three big pieces that make it a disease. Unfortunately, mental illness, kind of has a bad rap in the general public, the general public's mind frame, because we don't have a blood test, we don't have an X-ray or a CT scan that we can do in order to diagnose this person has cancer or this person has diabetes. With mental illness, it's very descriptive, and that can be unsatisfying, especially to scientists. But we do have a very long, rigorous way in which we can diagnose these illnesses, even though they are descriptive. I'll argue that our mind is the most complicated organ we have, and it's the one that we really can't live without and still be ourselves. And so it stands to reason that it is more complicated and more difficult to investigate and fully understand, especially when things aren't working the way that they're supposed to be working. So For any mental illness, the symptoms have to be consistent for what's generally called more than a reasonable time. So this will differ between depression, can be as short as 2 weeks, or post-traumatic stress disorder can be a diagnosis that requires a month or 6 months, depending on who you're speaking to and what kind of detail you're looking at. But we use the word consistent because it doesn't have to be constant. The symptoms that people are experiencing usually are more days than not, but it doesn't have to be every single moment of every single day. And it is usually much longer than 2 weeks, and these things can certainly happen for months at a time. Sometimes even feel like years that you've had a depressive episode or an anxiety state. So the second point is these must represent a significant change in the person's normal experience upon onset. So again, irritability is a symptom of depression. Some people don't know that. They think depression is just you feel bad and sad and depressed. Irritability without feeling sad can be a depression symptom by itself. However, if someone's personality is just to be kind of cranky, that isn't a change in their personality, their normal experience. So those folks, we just say, you're cranky, that's fine. And the third really is the most important piece, because social, occupational, educational, or other important functioning for that person must be negatively impacted by these changes. So for example, bipolar symptomology someone can experience, and if it's not negatively impacting their life, their relationships, then technically they don't meet the full criteria for it being a disorder. Same goes for autism spectrum, different things like that. If it's not negatively impacting them, it's technically doesn't meet criteria for the disease. It often does impact you negatively though, and impacting you negatively, even on a small level, does mean that you could meet criteria. So reaching out to a doctor if you're concerned or worried about it, that's the right person to talk to in order to sort those details out and determine, is this, does this meet full criteria, and are there things that could help you out? So I'll emphasize a few things here, that all mental diseases are real, biologically and environmentally driven illnesses. They can be episodic, meaning they happen, for a short period of time and then go away, and then come back again. They can be chronic, where once you develop those symptoms, they stay for a very long period of time, or they can be singular events. So people can have a psychotic episode and never have another psychotic episode in their life. Same with a depressive episode, or maybe a panic attack or something. You can have one and never experience it again. Many, if not all, of the mental diseases are preventable. Many are preventable. And what's really, really good and is underappreciated by a lot of folks who don't study this, who aren't in the field, don't realize that the vast majority are highly, highly treatable. So we'll talk about a couple of those details later, but what we also know that's really interesting and a little bit unique about the mental illnesses is that in comparison to certain things like physical illnesses, developing cardiac disease or COPD, chronic obstructive pulmonary disease, it turns out with mental illnesses, a healthy climate and culture is critical. Community support is critical for people to engage in care, to continue to engage in care, and to really get better. So there are other illnesses that people can develop, physical illnesses that are, so long as that person has the information they need and the care and the access they need, they're good to go. You can manage that on your own, no matter what amount of stigma there is. Whereas mental illnesses really have been shown through the literature, through epidemiological studies, to require community support in order for people to really engage in care and get better. So now I'm going to go through just 3 things. This is going to be kind of lightning fast. So I'm happy to speak about any of these in further detail. We also have some YouTube videos of our full mental health literacy talk on YouTube, as well as one specifically on depression. So a scientist primer on depression is on our YouTube channel. You can see way more about that if you'd like. But I'll talk a little bit about the mood disorders and anxiety together because they tend to happen together quite frequently. So the mood disorders are also, and anxiety are the most common of all the mental illnesses. So mood disorders include depression and bipolar disorder. There's a few different types of both of these, but it's not that important here. It matters more if you've developed it or someone you love, you care about has developed it and needs to determine exactly which kind you have in order to find the best treatment for you. But depression and bipolar disorder has both depression as well as manic episodes. And then anxiety, maybe 2/3 of people with depression will also have anxiety and vice versa. So they do overlap, or they're comorbid. They happen together quite frequently. And so in the general population, if you're looking at, say everybody in a room, in a totally general population, you would expect about 6.7% of people to currently meet criteria for depression or bipolar disorder, and about 6% of people to meet criteria for anxiety disorder. And these are, like I said, some of the most common of the mental illnesses. Whereas, very concerningly, we found in the 2018 paper in biotechnology, Evans et al., found that in graduate students, so I think it was international, it was both Europe and North America, they evaluated about 3,000 or so graduate students in a variety of disciplines and found that it was 6 to 8 times higher point prevalence. So people were meeting criteria, graduate students were meeting criteria for depression and bipolar disorder, 39%, not 6, and 41% met criteria for anxiety disorder. So this is alarmingly high, and it's a big, big issue for us. It's also a really big issue. I mentioned at the beginning, part of my motivation is that I've lost friends and colleagues to suicide and depression. And suicide, it turns out, is due to 80 to 90% of them are found to be due to an underlying mood disorder. And so that's another good reason to really focus on mood disorders and identifying them early and making sure that people who are struggling with them are getting the treatment they need, because it can be a terminal illness. So it turns out that the best way to treat and prevent suicides is to treat the underlying mood disorder. And if someone is expressing suicidality, thoughts about suicide, it is not dangerous to ask them directly. Please do. Will not increase their chances. It actually reduces the likelihood that they will make an attempt. And the other 2 things that are really, really important to do is to restrict access to lethal means, and for that person to avoid substance use, which can make them more impulsive and more likely to try something. So the symptoms can actually affect all kinds of things. They're called mood disorders, but it affects the body, it affects behavior, it affects thoughts, which can be very alarming and very disturbing, especially for folks like us that use our minds for our work. And the causes are myriad as well. So the immune system and endocrine dysfunction can lead to these very specific signs and symptoms and experiences, and treating those underlying immune and endocrine dysfunctions can ameliorate the mood disorder. It's really remarkable. If you have a thyroid disorder, you can then treat the thyroid disorder and the depression or the anxiety goes away. Nutrition, sleep, or exercise deficiencies can induce these, as well as people are probably familiar with selective serotonin reuptake inhibitors, or SSRIs. It's the most common type of antidepressant prescribed. And so it does involve the serotonergic neurological pathways in your brain too. There's a lot of genetics that is involved, and we also now know that a huge amount of risk is involved with trauma, childhood trauma, current trauma, events that are happening now or in somebody's past will make them more likely to develop a depression, bipolar disorder, or anxiety. And so I spent a lot of time on this. I'll go through the next two a little bit faster. But I do want to emphasize that experiencing depression, experiencing anxiety does not preclude you from being a successful researcher, scientist in academia or in industry. Professor Kay Redfield Jamison wrote an absolutely incredible book, memoir, about her own experience living with bipolar disorder. And she is one of the world's experts on bipolar disorder and is a phenomenal clinical researcher, professor at Johns Hopkins. So her book, An Unquiet Mind, is a beautiful example of how she was able to treat her illness, her very serious illness, and be able to go on and be one of the most famous professors in the mental health space. So related to depression, but different, is something called burnout. And one of the major pieces about burnout is that it's work related. It's almost exclusively work related. And so the symptoms of burnout are emotional or physical exhaustion, reduced resiliency and adaptability, becoming cynical about work or colleagues that you work with, and often reduced performance and ability to concentrate. So some of these things overlap with depression. So if you're not sure, it's good to explore these things with a clinician to really determine it. But we know that the causes of burnout are chronic stress relating to work or other ongoing activities, feeling a lack of control, especially in the work setting, or specifically experiencing bullying or toxic work environment and relationships. So you can kind of bin this all together in the catch-all phrase, work-life imbalance. What we have found out in recent years of research, which is really wonderful, is that there are very specific things that help with burnout. And it's very specifically taking breaks or vacation. So we have this chronic, culture of overwork in academia, in research, where even if we have a guaranteed vacation, a lot of people don't take it. And when people are experiencing burnout, these signs, these symptoms, and you can identify some of these causes, taking breaks or vacation are the fastest and most effective way for you to actually get back to your highest capacity of being able to work and engage and enjoy what you do. So another thing you can do is negotiate better hours or specific accommodations that will help you not, overtax yourself, or improve communication. Seeking support and actively building better relationships at work can help create resiliency. And then mindfulness, sleep, and exercise are things that really work well for burnout. And so if you've tried kind of all of these things and you're not feeling better from these kinds of symptoms, then it might be something more severe like depression that would require psychotherapy or respond really well to pharmacological intervention. So that's something to think about and explore. And then the third and final illness itself that I'm going to talk about is talked about not enough and tends to have a lot of culture in academia and at conferences. I know we can't really go to conferences right now, but we will again. And many of the conferences that I've gone to have a pretty heavy drinking culture around it, for example. But so when does consuming a legal substance in a social setting cross that line into substance use disorder? And so the symptoms are things like daily use or binge behavior. So maybe you don't drink during the week, but on Saturday you drink 20 drinks. That could be considered binge behavior. If somebody experiences blackouts, or they find that they're lying about their use to their friends, their family, their colleagues, if cravings or use itself is impacting their work, their relationships, their friendships, or is impacting their mental or physical health. These are all things that move from use to substance use disorder. The causes, and this is one of the things that really gets me and makes me want to always bring this up in mental health literacy talks, is that very few people really recognize and understand that substance use disorder development is highly, highly genetic. So we have really good studies that estimate that 40 to 60% of the likelihood of developing a substance use disorder comes from the genetics. So it can also be initiated by using it as a coping behavior, or what a lot of people will call self-medication for some other mental illness that they might have. So if they're struggling with depression or they're struggling with anxiety, they might drink quite a bit in order to calm themselves down and interact with that, as opposed to getting the psychological and medical care that might benefit them. They might develop a substance use disorder instead, which is really unfortunate because alcohol, for example, is a depressant itself, so it will make depression worse. There's a lot of social pressure, and there's easy access to a fair number of types of substances that can lead to dependence. And it's also linked, like I said, to mental disease. If you have depression, your likelihood of having a substance use disorder is higher than people who don't have depression, and vice versa. So we now know that opiate use, pain use for control of pain, that can actually induce depression in individuals. The good news is that we have treatments that help. So detox programs, support groups to maintain sobriety, individual and group counseling, and especially peer support. So not peer pressure of why aren't you drinking at a social event, receiving instead peer support of I'm not drinking and saying, great, good for you, and leaving it alone. That is really supportive and helpful for people who have developed or have a risk of developing substance use disorder. And then treatment of the co-occurring mental health disorder, if they have one, is really, really important too. So I'll just go back through some of these points before we get into the isolation piece and touch on a couple other things. So 80% of major depressive episodes respond to standard treatment. This is information from the American Psychological Society. So it's treatable. Please seek treatment. Don't be skeptical that it's not going to work. Awareness, early identification, and early treatment are really key to not worsening things. So unfortunately, studies have shown us that the average person waits 6 to 8 years after developing initial signs of depression before they seek treatment. This is extremely problematic because the longer a mental illness goes untreated, the more other comorbid disorders can develop and complicate that recovery. And then that delays the treatment response. So the earlier you catch it, the earlier you engage in treatment, the easier it will be to treat it and manage it. And then I'll reiterate what I said at the beginning. Community support and encouragement is hugely impactful for seeking care, sustaining treatment, and recovery. So graduate students, like I said earlier, have 8 times higher rates of severe depression and anxiety. And the causes of this might be in part due to the intense environment, how cutthroat and, publish or perish, unfortunately, our culture is. But also it could be that the folks who end up in academia and in higher education programs, people with higher IQ, people with higher educational attainment, we've found report higher rates of mood disorders, and yet they're less likely to seek treatment for them than people with lower IQ or lower educational attainment. So something unique about us. So I do want to emphasize that the diversity of experience also impacts people's the environmental aspects of the stress. So these are called minority stress, and different people who belong to different demographics, women, people of color, LGBTQ individuals, international students, people who have left their home country to go study somewhere or work somewhere else, first generation students. All of these people are experiencing things that if you don't belong to that subset, you may not be aware of, but these can be, range from minor to major trauma for them. And when somebody belongs to more than one of these groups, that can often lead to more than additive effects as well. So there's one comparison I like to make, and that's for us to elite athletes. Serena Williams is one of the most amazing athletes and accomplished people in the entire world. And yet when she experiences injury of her physical body, what she uses for what she does, she gets care immediately in full view of the public. And unfortunately, we in academia, when our minds, our instruments, of our work is become injured, we often just try to push through for as long as we humanly can, getting ourselves to that crisis point. And so I'd invite us all to try to change that and move away from that kind of modality. So next, we're going to talk about the pandemic and what has changed. So around this time last year, worldwide, we were all made aware that there was a new virus that was going to probably spread or has already spread around the world. And with any kind of crisis, there's this interesting graph here that, so at the onset of a disaster, there's usually, emotional highs versus emotional lows. This is on the y-axis. We'll experience, the impact finally hits you. And then we've got this like heroic or honeymoon phase of everybody gathers together and does what needs to be done in order to address the initial impact of what's going on. And so this is something that will often happen, followed by a huge crash with a lot of, more triggering events, various things happening, and then eventual recovery over time where we start to build back normal. What's different about this pandemic is that it has lasted so long. There is not one singular event. There have been so many events happening to us all over the world, wave after wave of this pandemic, shutdowns, then reopenings, then shutdowns again, that this is not, some version of this kind of natural, normal response to a crisis is something that's happening, but it's all out of sync. Everyone's going to be experiencing it differently. Many people are losing loved ones, they're losing jobs, they're really restricting where they're going, really disrupting their lives, especially within academia. I personally, I had 3 or 4 jobs kind of lined up to look around this time last year, and all of them disappeared. So, you have the pandemic to thank for me to really step into this role of CEO of Dragonfly. But that's a silver lining approach. But some of the things that people are experiencing here because of the pandemic are lack of physical contact with others, their family members, their colleagues. A lot of us who are working from home. If you can't work from home, there might be extreme stress or anxiety around worrying about catching this virus because you have to go into lab, you have to go into work, and you get exposed more likely. Temporary unemployment, stop of bench research can be extremely disruptive for researchers and scientists. and uncertainty for the future, financially, health-wise, travels, other plans, everything we had going on. And then add on top of that for folks in the young professionals group, likely, many people have children and are now having to homeschool them. So that can be an incredibly difficult burden for them as well. So overall, I'll say, as Dragonfly has interacted with the folks in academia, at academic institutions, scientific societies, we're finding that maybe 70 to 75% of people respond to our surveys, our questions of, are you doing better or are you doing worse? Or no change. About 75% of folks in the academic institutions have reported their mental health is doing worse. And so there are some people who are doing better and thriving, and that's for different reasons. It depends on where they are in their career. It depends on what kind of supports they have. It depends on their personality. There's a lot of folks with maybe social anxiety who are doing much, much better being able to work from home and not having to interact with people quite as often as they had to at work, which was not ideal for them. So it's just important to keep in mind too, is that there's a diversity of experience. So I'm just going to emphasize a few things that have been found in studies. So there was a review that was done. It was a rapid review that identified 13 studies that showed very, very clearly that negative psychosocial outcomes are happening because of the pandemic. Depressive symptoms, anxiety symptoms are going through the roof. Anger, stress, post-traumatic stress, all of these kinds of symptomologies are also increasing. Social isolation, feelings of loneliness, and increased stigmatization. So that 2018 paper that I mentioned earlier that showed that graduate students had 6 to 8 times higher rates of depression and anxiety, that was before the pandemic. So it is now worse in all likelihood. So the conclusions that they made in this review was that extensive negative consequences for mental health are happening, and prevention and intervention approaches are really, really necessary and required to attenuate this psychosocial impact. There was a big study done in the UK. So for those of you who are in the UK, I highly recommend looking up this study by the University College London. If you'd like to know more, they got 90,000 respondents and were tracking how they were doing. And some of the major findings were that there's a big age discrepancy. And so that's really important for this group. And one of the things that I wanted to bring up was just to emphasize, folks 18 to 29 have much higher depression here. And it kind of went up right after the initial shutdown in March of last year. And it is getting a little bit better, but it's still above baseline. So the age group 30 to 59 as well, still far above those who are more at the mature stage of careers, 60 and above. So that's something both for depression that we see and for anxiety. So if you're feeling these things, if you're experiencing having less control, less ability to go from stressed, distressed, or even diseased back to that mentally healthy state, that makes sense. You are part of a large group of people feeling this way, and it's because of biology. And so I do want time for questions. So I just want to emphasize very quickly, if you're interested in the acute stress versus chronic stress response, this is an entirely complicated, wonderful system to look into and learn a little bit more about your parasympathetic and sympathetic nervous system that interacts with a whole host of your endocrine system to control your biology, to control your mind, your heart rate, your breathing, all your attention, your speed of thought, the fight or flight response. All of these things are things that are biologically driven and evolved in order to help you respond to acute stress normally. We are now a year into almost completely unabated chronic stress. And when we experience chronic stress, these systems that have evolved over the millennia do not function the same way and start causing more problems for us. So what do you actually do about this? And the short answer is you do the best you can with where you're at. So you can try to manage your environment to minimize anxiety triggers and maximize anti-anxiety experiences. So when stress is chronic, you're often going to experience sleep disturbance. Sleep disturbance also exacerbates depression, anxiety, other mental illnesses that people might develop or have already. This makes it a lot harder to handle the anxiety, to handle the daily stresses that you're going to have. And so the thing to do is to acknowledge these feelings are very reasonable, and you can try to practice guided meditation, for example, before you go to bed. Really be thoughtful and careful and use a lot of sleep hygiene in order to, it may take more effort in order to do what you used to do very naturally, very easily under non-pandemic times. Emotional control is going to be impaired during this time as well. And so this is the chronic stress. Your neurological system is in this constant chronic fight or flight or freeze mode. And so you are doing something, reminding yourself you are doing the right thing by staying home, by not going out, by being safe. These are things that you are doing even when you feel like you're not doing enough or you're not doing it what you need to be doing. Rumination, so racing worried thoughts, focusing on one thing is something that can happen quite frequently with anxiety and depression and isolation induced types of things. There are fewer things to distract you. But one of the good things is you can hack your brain. You can only focus on one thing at a time usually. So if you can switch the rumination subject and turn it to something else, that is a really good way to avoid the negative rumination and give your mind something else to be doing. And then a big piece of what's changed for a lot of us is the loss of structure. So you can create new structures. So introduce, before you start work, before you sit down to your computer, morning walks, coffee, so on. You can introduce breaks in your day, set an alarm so that you actually take a lunch break, put a blanket over your computer when the end of the day has happened. Turn off your email, delete your email from your phone if you can. It's close by. If you really need to check it, you can. But to create structural separation for yourself and create structure where there might not be any is really good. So with that, I'm going to stop, and I would love to open it up to questions.